Yeah, I think there are two ways to look at this. One is, what did the legislation do within Medicare, and then in the broader system? There's no question that within Medicare there are some steps taken in reform that are going to slow down the increase in Medicare spending. Medicare spending is still going to go up, but not quite as fast as it was projected to go up, and that's a good thing. One of the issues I think we don't pay enough attention to is the fact that Medicare beneficiaries' co-payments and their deductibles are tied to the rate of growth in Medicare spending. And so if we can slow down Medicare spending, we can hold down the costs that Medicare beneficiaries are paying out of their own wallets, and that's important. So there are some very important steps in Medicare, slowing down what we pay hospitals, for example, getting rid of the overpayments that the insurance industry has been getting in the Medicare Advantage plan, and this is, of course, has been going on for many years, and the irony being that the idea of bringing HMOs and private insurers into Medicare was to save the program money. And as long as this program has existed, it's actually cost Medicare money. And so if these plans really are more efficient, they should get a chance to show that. And they should get a chance to show that not by being overpaid by $1,000 per person, which is roughly what they've been getting, but instead by competing on a level playing field. So I think that was important to do. There are other things that are more speculative, creating this new Medicare commission, this independent payment advisory board that's going to take a look and recommend down the line what to do about Medicare payment policies. We don't know how that's going to turn out. The Medicare Commission on geographic variation and what the program pays. Those things are speculative, but much of the Medicare savings, I think, is pretty solid. The second question is, what does the law do to slow down healthcare spending more generally? And John Gruber, who's an economist at MIT, summarized the philosophy of the law recently when he said that this is like taking a bunch of spaghetti and throwing it up against a wall. When MIT economists are talking about pasta and cost containment, I get worried. I don't know if he's a good cook, but I get worried. But I think that is a pretty good analogy. The law has several main policies that attempt to control costs. One we discussed are the Medicare savings, but that's not system-wide, and it's important, but controlling costs in Medicare doesn't do anything about costs outside of Medicare. The second thing the law does is impose in 2018 this so-called Cadillac tax, which is a tax on high-cost insurance plans. I have a lot of concern about that because the difference in cost between insurance plans is not explained just by the generosity of benefits. So we're going to tax these so-called Cadillac plans that are supposedly excessively generous. The difference in cost between insurance plans is explained a lot by demography and sicker populations. And my worry, and I think a lot of people worry about this, we actually could increase underinsurance in the United States. But beyond that, even if you believe this is a good thing, and even if you believe it's going to work to control costs, it's very controversial. Middle-class people don't like the idea of having their benefits taxed, and that's why they pushed it to 2018. And if the most important element of cost control is now coming to 2018, you've got a problem. So that's the second leg of the stool. The third leg is what I would call delivery system reform. Electronic medical records, disease management, paying for performance on the basis of quality, not quantity, talking about accountable care organizations and creating integrated systems of delivery between hospitals and physicians. I think all those things are worth doing, and in fact, I think many of them are worth doing even if they don't save any money. The problem is there's not a lot of evidence that any of those are going to save very much money in the short term, and probably some of them are actually going to cost money. And so this is the spaghetti, or as I would say, this is throwing darts. We're just throwing a bunch of things at the board, hoping that some of them hit. I don't think that's a very good way to control costs. It's not a very reliable way. It may work better than I'm suggesting. It's certainly not reliable. It's certainly not the way that other countries control costs. And so I think there are a lot of questions in the long run about how effective this law is going to be in cost control. Other countries, when they move to universal health insurance, and we should always remind ourselves that we certainly have made a great stride forward. We're not at universal health insurance even when this law is implemented. When they implemented those plans, by and large, they didn't control costs. They actually paid providers off to get their cooperation. They spent more money. The cost control came later. But we've waited so long to expand coverage. We're in a different position. I think if you ask the question, could the administration have gotten more in cost control and still pass the law? I think the answer is probably no. I think they got actually more than I thought they would get, and probably about as much as they could have gotten, because cost control, as we've said over and over, means controlling the flow of income to the healthcare industry. And they all say they're for cost control until the flow of income slows to their industry, and then they're not for it anymore. So it's a very difficult thing to do politically. The Clinton administration had a very strong plan to control costs with a premium cap and a de facto budget. They got killed. Obama didn't want to repeat that experience, so I think they went light on cost control. And I think what they really did is they emulated the Massachusetts model. And the Massachusetts model was, it's hard enough to just enact a big expansion of coverage. Let's defer the cost control till later. Let's sort of talk about it, but not really do that much. And then we'll do it later. I think that's what they did at the federal level. And we should say that this actually can cause a transformation of health politics. If you look at Massachusetts, they have seen those premiums go up very much after reform. And yet now the state is implicated in this because there's an individual mandate and there are penalties and there are subsidies. And so they're having very serious conversations in Massachusetts about how to control costs. I think the same thing's going to happen at the federal level, that once the federal government starts paying for this post 2014, you're going to see a very serious debate about how to control spending. Having said that, Massachusetts actually hasn't adopted any of the serious proposals to control costs yet, which shows how difficult this is to do. But I do think you're going to see a transformation of health politics at the national level. There's no question there's a lot of medical care that's wasted in the United States. There's no question that there's quite a bit of medical care that is risky, that's given to people without a lot of benefit. So it's there, but it's hard to get at. Everybody can talk about it at a sort of big level. When you get down on the micro level and you try and design policies that reduce wasteful care without reducing necessary care, it becomes very difficult to do. So I think we should move forward on delivery system reform. I think we should think through if we can come up with incentives and different way to organize care, different ways to manage primary care, but I'm not particularly hopeful myself that this is the silver bullet. And the other thing we should add is that utilization is not the primary driver of healthcare, higher healthcare spending in the United States. And this is something that's repeated endlessly in the debate. If you go to Canada, you'll see that they have geographic variation in medical care in Canada too, but of course their spending's at a much lower level. And so the United States does certain high-tech, expensive things more than other countries, certain kinds of cardiac surgeries, for example. But what is very much different in the United States than other countries is simply price. We pay everybody, not just doctors and hospitals, but drug companies, insurance companies, medical device manufacturers. Everybody makes more in this country. And until and unless we're willing to do something about that, costs are going to keep going up.